Good afternoon, everyone. The title of our project is Analyzing the Utility of Repeat Head CTs in Patients with Isolated Traumatic Subarachnoid Hemorrhage and Reassuring Initial Exam. Now, this is quite a mouthful, so let's just have some fun and call it Things That Go Bump Your Head in the Middle of the Night. Sorry, I just couldn't resist a little seasonal Halloween fun. We have no disclosures for this project. Just to give some very quick background, the term subarachnoid hemorrhage refers to an intracranial bleed that occurs below the arachnoid mater, which is the second of three protective membranous layers surrounding the brain, known collectively as the meninges. Subarachnoid hemorrhages have a variety of known causes, including aneurysmal rupture and vascular malformation. However, one of the more common causes, and the one that we are concerned about for this project, is head trauma. When a patient presents with head trauma and a traumatic subarachnoid, the current standard of care often involves hospital admission with several hours of observation and at least one, but sometimes multiple, additional follow-up head CTs. This surveillance strategy has presumably developed out of an abundance of caution, not wanting to leave anything to chance with a brain bleed. However, this strategy may be overly cautious and as a result unnecessarily costly. Several published papers have shown that patients with isolated traumatic subarachnoid hemorrhage and an intact initial neurologic exam often do well and very rarely experience any functional deterioration. If this is true, it would certainly call into question the need for repeat head imaging. With that in mind, our goal with this project was to explore two main questions. One, do patients with this presentation ever require neurosurgical intervention? And two, if they do, is it the repeat imaging itself that is driving the management decisions? The study setup was relatively straightforward. We ran an RPDR query to gather patients presenting to either BWH or Mass General with traumatic subarachnoids over the last 20 years. We then screened these patients with the following exclusion criteria, which you can see on the screen: age of less than 17 years, an initial GCS less than 13, and the presence of any other form of intracranial hemorrhage, whether it be subdural, epidural, interventricular, so on and so forth. A variety of data points was then collected, the most important of which was length of stay, the number of CT scans over the course of their stay, and the official radiographic reads of these various CT scans. The endpoints we were interested in were A, was there any hemorrhagic expansion at the time of repeat imaging, and B, was there any negative neurological outcome, whether that be deterioration in exam or deterioration in GCS score or a need for neurosurgical intervention. To date, we screened over 1,000 patients with a total of 237 meeting criteria for inclusion, ranging in age from 20 to 94 years with an average age of about 67 years old. The average length of stay was between 3 and 4 days, but was generally dependent on total trauma burden. Of more importance for the purposes of this project, 210 of our 237 patients, or about 88.6%, received at least one additional repeat head CT. Of the 210 patients receiving multiple scans, only 9, or about 4.3%, had a subsequent CT that showed any degree of increase in the hemorrhage. 8 of these 9 had an increase that the radiologist described as slight, mild, or minimal, while only 1 demonstrated an interval increase significant enough to cause structural change, in this case ventricular enlargement. Moreover, this one patient was the only patient in our entire study who required any invasive neurological intervention. In this case, it was an EVD. We should note, however, that in this particular case, it does appear the decision to place the EVD was based solely on the imaging and not as a result of any functional change in neurologic status. Even with this one notable exception, however, our results indicate that patients who present with isolated traumatic subarachnoid hemorrhage and a reassuring initial physical exam rarely have definitive hemorrhage expansion at the time of follow-up CT, and they almost never require neurosurgical intervention. And the one notable exception on the slide before, a reasonable discussion could have probably been had at the time about the merits of placing the EVD in the absence of neurologic decline. As such, given the monetary costs of CT scans and the radiation burden they present to patients, it may be safer and more cost-effective to use serial neurologic exam as the initial guiding factor in treatment decisions, rather than automatically relying on additional scans. Repeat scans could then be utilized more judiciously in cases where the patient's overall presentation is indicative of neurologic deterioration. Overall, we would still like to have some more patients before we make a final determination on that. With that, I would like to end. I would like to thank Dr. Smith and the entire CNOC team and the CNOC Symposium for giving us this opportunity.